Good afternoon. Welcome to HL7 Da Vinci Community Roundtable. Today's session is Da Vinci Implementation Guides, Solve Your Real-World Business Problems, Postable Remittance Advice, Payer Data Exchange, and Burden Reduction Overviews. My name is Alex Goss, and it is my pleasure to moderate today's Community Roundtable and to remind all of us that we engage in these forums under HL7's antitrust policies to ensure appropriate collaboration and information sharing. We're grateful for your interest and participation in Da Vinci's Community Roundtable. Today's sessions contains 3 presentations from Da Vinci leaders. First, we'll introduce the newest use case, focusing on postable remittance advice. We'll then pivot from our newest use case to share an overview of several implementation guides recommended in CMS 0057 Interoperability and Prior Authorization Final Rule. This includes payer data exchange and burden reductions, coverage requirements discovery, documentation templates and rules, and prior authorization support. With the issuance of new federal interoperability rules, the innovative interoperability work advanced by the HL7 project is once again being recognized as a path forward for game-changing industry transformation that will reduce burden, increase automation, and improve care. Today, you'll learn how to access the resources, participate in community feedback, and start getting involved. Our presenters today include Naomi Miao, Business Operations Manager at Athena Health, Mark Scrimshire, Payer Data Exchange Project Lead and Implementation Guide Lead of the Da Vinci Project, and Chief Interoperability Officer at Onyx Health. Bob Dieterle is HL7 Da Vinci Project Senior Advisor and our Burden Reduction Lead. Please use the question function in the Zoom platform throughout today to submit your questions. We do have the lines muted, and you'll need to use the question and answer box as we've disabled the chat. There will be a survey that'll launch at the end of the webinar, and we look forward to your feedback. So let's dive in with a little bit more housekeeping. Our next community roundtable will be March 27th, and we will have today's presentation and slides anticipated to be posted tomorrow. Few industry events that I would like to share with you. We will have a great presence at HIMSS 24 on behalf of the Da Vinci Project. So please stop by and see us. Consider attending the open house on Monday night of HIMSS, as well as visiting one of the 11 spotlight presentations, and visit with our members at both the Da Vinci kiosk and the HL7 booth. So please stop by and see Da Vinci's in action and learn more at the various educational opportunities, which include overviews on payer-to-payer, CRD, PAS, CDEX, and clinical data exchange and price cost transparency. We'll also support the State Health IT Connect event this coming April and the WEDI Spring Conference. Several upcoming HL7 events to tout include the inaugural launch of the FAST Accelerator's new webinar series called Fast Focus. This virtual, free, quarterly webinar series starts with level setting on the FAST Accelerator, its history, purpose, and projects, as presented by Alex Contour of ONC, Duncan Weatherston of Smile, and who's the co-chair of FAST, and also FAST Technical Director Dave Pike. With May approaching quickly, that means it's time for another HL7 testing event called a Connectathon, which will be followed by the HL7 working group meeting, which both are being held in Dallas. These are all great opportunities to learn and engage with industry leaders. The Da Vinci Project continues to expand its membership, and we're thrilled to share our newest members representing providers, payers, vendors, and QHINs, Qualified Health Information Networks. This includes Baptist Health, located in Florida, Blue Shield of California, Blue Cross Blue Shield of South Carolina and their Palmetto team, Cohere Health, Highmark, eHealth Exchange, and Health Gorilla. We are continuing to expand our membership, and we'd love you to consider if Da Vinci Project is an initiative you'd like to engage in to help set priorities and direction. help fund subject matter experts and management that advances the project and its implementation specifications on a predictable cadence, get involved and drive use cases and lead industry dialogues, and further help advance the exchange of value-based care standards. So there's some more details in the slides, and you can certainly reach out to Da Vinci PMO at pocp.com with any questions or expressing your interest to join. Finally, I'd like to ensure you're all aware of existing use case call meeting schedule. I'm sure we'll have an update on this next month as we finalize our planning to launch our newest use case, Postable Remittance Advice, which is a nice segue for me to introduce our first presenter. I'm asking her to come on screen. So Naomi Mao of Athena Health, I'm going to advance your slides. So you might want to come off mute and you can let me know when you're ready for me to continue to advance them.
All right. Thank you, Alex.
Sound great.
Can you hear me okay?
You sound great. Take it away.
All right. Hi, everyone. My name is Naomi Miao. I am a business operations manager at Athena Health, focusing on API partnerships. I am representing a group of folks from different segments of the industry who all joined together during last year's discovery on the need of having a postable remit fire IG. So our discovery group was made up representatives from Da Vinci, of course, Athena Health, Optum, MinuteClinic, Centene, and Cigna. Before we get started, I just want to take a moment to thank all of them for their invaluable participation in our joint efforts. So to get into it, the specific proposal we have been discussing is a postable remit fire implementation guide. My goal here today is to share with you all on a brief overview of the use case and what has come out of the group's discovery efforts. And in doing that, I want to hit a few key points. I want to be able to share with you what the key business problem is and what we're trying to solve, how the providers today are dealing with the problems, and our ultimate proposal for a fire-based solution that does a significantly better job at addressing that problem. So if you look at the slide today, EDI transactions are being utilized to obtain 835s. So the business problem here is quite simply that providers don't always cleanly get their remits from payers or clearinghouses via 835s for the claims they submitted. Next slide, please. 835s and paper remits tend to get lost. And then when they're missing, it takes time, money, and effort to track them down. So in situations where remits are lost, there is a need to retrieve a duplicate copy of a previously issued remit in an automated fashion to allow for efficient, timely, and accurate payment posting. So the postable remit fire use case serves that purpose. Next slide, please. So before we get into why remits tend to get lost in the first place, I just want to highlight that this use case is not trying to replace 835s. The postable remit fire use case would neither corrupt nor impact the initial 835 transactions compliance with the current standard. There is not an existing EDI transaction that allows providers to request a duplicate copy of an already issued remit today. So the postable remit fire IG can bridge that gap and bring automation to the missing remit retrieval process, which is currently manual today. Next slide, please. So why would there are a couple of prevalent reasons of why a remit can get lost. Remits tend to get lost regardless of whether there is a ERA enrollment or not. And sometimes the ERA enrollment isn't even an option. So just to preempt some of the questions that came up in the past, like, does an enrollment just fix this problem? Can providers just enroll for ERA with payers or clearinghouse and this problem becomes a non-issue? The answer to that is no. And then we will explain that. And then you can see that these use cases either make ERA enrollment not possible or make ERA enrollment not effective for solving the missing remit problem. Next slide, please. So the first most prevalent reason for remits to be missing is what our discovery group called a shared TIN scenario. Different part of the industry may have different names for this, but we call it a shared TIN scenario. So according to a HIMSS survey, 71% of the hospitals and health organizations use multiple RCM systems. So basically, when multiple RCM billing systems bill claims under the same TIN, payer limitations often mean that remits don't reach all the entities that submitted this claim under this submitted the claims under this TIN. So I mean, that's a very brief overview of this because we only have 10 minutes here, but please feel free to go back to the slide and then you can use the details here to check what that means. The next slide has a link to that HIMSS survey. And Alex, you can go to the next slide. So another issue that contributes to the missing remits problem is that the same issue can occur when providers are in the process of transitioning from one EHR RCM billing system to another. So that's when, again, remits tend to get lost and don't get to send to the right place. There is the transitional period when the providers are transitioning off of an old EHR RCM system and are trying to get set up enrollment with the payer or clearinghouse on a new EHR or billing system that they're trying to transition to. So the remits tend to get lost and not get sent to the right billing system here. And again, there's more detail on this slide. In the interest of time, I'll keep moving forward. Next slide, please. So these are the two reasons that we talked about are more prevalent reasons, but there are all sorts of other reasons why remits can be missing for providers. I don't mean to oversimplify the issue, but there is no single all-encompassing theme here. Remits can get lost when the payers fail to return the remits when they return a check, which we see a lot. It could be, crossover claims for government payers that don't get processed correctly because generally crossover claims are very complicated and error prone, which could create claim processing issues for the secondary payers. It could be that the providers being submitted on the claim being out of network. And sometimes some payers don't allow out of network providers to even enroll for ERA, which could then cause remits to not get returned the way that it should. It could be that the claim is being submitted to the local plan instead of the patient's home plan, and then the general complexity of payer routing arrangement causes issues. And then it could just simply be that the paper remits got shredded by accident or got lost in the mail. So there are a lot of different reasons why paper remits and 835s could get missing, could get lost. Missing remits, it's an issue with many causes, but it's a prevalent and widespread issue. And then the result is that providers don't get their remits sometimes, and then they need to track them down. Next slide, please. So these are the main causes of why remits could go missing. We want to also point out that the current payer data outreach method are not very favorable to providers and to payers, and it causes operational problems. The way providers deal with the missing remit issue today is that providers have to go onto various of different payer portals or clearinghouse portals to track down missing remits, or make phone calls to the payers to have them fax over the missing remit. But that presents challenges because managing access to portals for so many different payer portals and clearinghouse portals, that is difficult to do. And it's hard to do this work at scale. The phone calls are very expensive, and then the hold time could be very long, and some payers don't even accept phone calls. So our discovery group talked through the challenges providers and payers are experiencing today, and we agreed that these are the prevalent challenges that are worth solving for within automation using a FHIR IG. Next slide, please. So that brings me to the ultimate point I want to make here. We wanted to double click on the fact that missing remit retrieval is a manual workflow driver today for revenue cycle work that can't be automated by EDI. The Discovery Group has agreed that a postable remit implementation guide is a great way to solve for these problems. Payers and clearinghouse can benefit it from getting fewer missing remit related phone calls and getting fewer portal access related phone calls. Providers and vendors can also benefit from it and see mutual cost reduction from phone calls and portals and other manual outreach methods, reducing the days in AR and fewer manual effort errors in this manual work that's currently handled by manual users. So automation opportunities present the possibility of a high ROI, which remove most of the needs for human interaction, which also reduces human cost errors. Next slide, please. We took this use case to CMS and National Standards Group end of last year, and we have obtained CMS and National Standards Group support to move forward with the postable remit use case end of December last year. So again, the postable remit FHIR API and then the IG would neither corrupt nor impact the initial 835 transactions compliance with the current standard. So we plan to use the FHIR IG and FHIR API to search for missing remits using payment information or claim information and download a duplicate copy of the 835 or paper remit via FHIR API. We're planning a use case public launch in March. So Alex, you can go to the next slide here. Yeah. We are planning for a use case public launch in March, and we would love to hear your thoughts, and we would love for your participation and discussion. Alex, anything to add here?
Thank you, Naomi. That was a great overview of the postable remit use case. It's been in development for a while for Discovery, and we're grateful to have the National Standards Group support for us to move forward with this, because it is another example of how the Da Vinci Project is really adding on to the existing install base and capabilities in the electronic data interchange world as mandated under HIPAA. And so this will provide an additional feature that can be integrated into practice management systems and EHR connectivity with payers to support that FHIR-based call. So the work that Naomi was referencing as discovery work was the initial sort of framing effort by the Da Vinci members, and we're going to finalize our launch plans here in early March as the leadership team gets together. We've secured an implementation guide author to help us with writing that implementation guide that will reflect the discussions that'll happen once the public use case calls launch. Hoping maybe in March, maybe early April. Stay tuned for more information there. We plan to have a listserv and have details on the conference call center, so you can join those calls. These calls are open once they become publicly launched calls. Everybody, regardless of membership, is invited to participate. So we would like you to think about how this use case may be of interest to you and your organization, and think about what subject matter experts, whether they're from the business side of the house or from the technology side of the house, that you may wish to bring into these discussions to influence the progress of this or the trajectory of this implementation guide. So we'll keep an eye out for questions. We don't have any right now, but we have a lot of additional content. So I'm going to say thank you to Naomi, and I'm going to queue up our next presenter. So you can stay tuned for more details on Postable Remit as that happens. And now welcome Mark Scrimshire to talk to us about Payer Data Exchange.
Hi there, Alex. Good to be here. So let's talk about Payer Data Exchange. So what is it? Payer Data Exchange basically enables a health plan to share key clinical data and patient history with both applications of a patient's or member's choice and with other payers, and now also with a member's providers. So This was originally included in the CMS interoperability and patient access rule, which goes back to an enforcement date in July of 2021. So it's well established. There are a lot of implementations out there. We've not been sitting around since then. We've actually published an STU2 update in January, and that added a prior authorization profile in support of the latest CMS rule. We're actually also working on providing those provider access APIs and payer-to-payer APIs that are required in the rule, and that's going to be the focus of an STU 2.1 update. So we are working towards that. PDEX also encompasses the work around formulary. So that was updated to an STU2 version back in August of 2022. Didn't really change the content, but it changed the way it was structured. And that is also being referenced in the latest prior authorization rule. PlanNet, or our provider directory capability, that had a minor update back in April 22. There's been a lot of implementations around that. And most of the work recently has focused around staying in tune with the work going on in the FAST National Directory Project. And so PDEX in the STU2 version was actually referenced in the CMS prior authorization rule, CMS 0057, that was finalized and published in the Federal Register on February 8th of this year. So as we look ahead, I think the two key things that are going to come, and we'll talk about in this session today, is really provider access API. So that's a bulk API. It basically enables an in-network or contracted provider for a health plan to go knocking on the door of the health plan and say, tell me what you know about my patients, and being able to receive clinical data, non-financial views of claims and encounter data, and prior authorization data. The payer-to-payer bulk API will also be part of what comes in the update. And that really meets the scenario where a member moves from one plan to another, and they'll be able to offer up their prior plan information, so their subscriber or member ID and the plan that they were a part of, to their new plan, and basically say, yes, I want you to go get my data. And that plan will be able to pull basically the same information, but only stretching back over 5 years from the request date, to get information about the payer's clinical data on the member, their non-financial view of their claims and encounters, and critically those prior authorizations that are still active or have changed status in the last 12 months. So we'll also be looking, as we go through this and dealing with these bulk exchanges, as to how we handle the registration of both providers and payers to be able to access these secure APIs. Let's go on to the next page. To give you a picture, it is relatively complex, but let's try and break this down. So payers have a lot of clinical data that they collect that needs to be made available to members, and now to potentially to payers and providers. That's the core purpose of PDEX, and that was really featured in the CMS Patient Access API, the CMS 9115 rule. At the same time, the Karen Blue Button, the Karen Alliance's consumer-directed payer exchange, are focused on making full claims and encounter data available to members through those same APIs. With the prior authorization rules, CMS 0057, we've talked about the provider access and payer-to-payer bulk APIs. The Karen Alliance is really producing non-financial views of those claims and encounters, and payer data exchange will expand, not only pulling in that data through these APIs, but will also add the prior authorizations and the supporting information that goes into making the decision. Let's move on to the next slide. So, patient access API. Payer has their various product designs and various data sources. They're supporting the discrete implementation guides for Da Vinci Formulary, for payer data exchange, and also for Karen Blue Button. And all that goes out through a Smart on Fire security layer to allow consumers to connect apps to that data. Let's go on to the next slide. So, provider access API, what this is doing is payers will need to manage an attribution list for their in-network providers. Payers will be able to potentially take that data from their claims to have really proof of an existing treatment relationship. They will also potentially be able to take data from other sources to be able to keep those attribution lists up to date. Providers or a representative of theirs will be able to come in using those attribution lists to be able to pull the data that we've talked about, the non-financial view of claims, any clinical data, and particularly those prior authorizations, and be able to receive those via a bulk FHIR API. That data can actually stretch back, just like the patient access API, as far back as the 1st of January 2016, as per the original interoperability rule. But if we go on to the next page, I think we'll look at the payer-to-payer API. Sorry, we'll go for the PDEX provider. Let's delve into the details of this. So the attribution list. A payer will have their own rules about how they manage those attribution lists. Where will they get the data from? Basically, from claims history is the most likely starting point. There'll also be the option for members to opt out of any data sharing with providers. And if a member makes that declaration or reverts it, then the payers will need to update those member attribution lists to either add or remove the member from a given provider's attribution list. Payers will, as I say, have their own rules about how they're constructing that list. Will they take 1 year's worth of data? Will they take 2 years, 18 months? It really becomes their choice based upon the nature of their business. But additionally, as Bob will cover in the next section on prior authorization, there are some emerging hooks coming out of the clinical decision support framework, where the CRD, the Coverage Requirements Discovery implementation guide that Bob will talk about, also has a couple of interesting hooks. One is for an appointment book, and the other is for an encounter start. So these could actually be used at the payer's choice to actually be an evidence effectively of an impending treatment relationship. So that starts to cover the scenario where a member turns up with a provider that they've never seen before, but the provider could make use of data that the plan may have about that member so that they can have a more useful first appointment. We're not requiring those, but they will be available as an option for payers to be able to use. So the net result of those attribution lists is to create in FHIR terms a group profile that will have the list of every member. And the provider or their authorized representative, which may, for example, be their EMR, will be able to query for one or more of those attribution lists. And then using that attribution list, we'll be able to make queries through what we're calling the Da Vinci data export operation to retrieve the data that they feel is relevant to support their interaction with the patient. And that will pull from this pool of information, the non-financial claims and encounters, the clinical data and the prior auths. Again, we're trying to put this we're creating an API that will be useful and not just meeting the compliance rules. So we are definitely looking for inputs from the provider and payer community as we finalize this API. let's move on to the next slide. So payer-to-payer, the bulk is another bulk API as per the requirements of the CMS interoperability rule. That will work slightly differently. When members move from one plan to another, effectively a payer could, as part of the enrollment process, or maybe through their member portal, provide the option for a member to say, yes, I want you to go and get my data from the old plan. This is what I want you to go and get in terms of, is it all of the data or is it just the non-sensitive stuff? And they will provide their demographics, they will provide the information about their prior coverage. So typically their subscriber ID, maybe their group and plan, etc. Typically the information off the coverage card. And the payer will also construct effectively a consent that says, yes, the member did want me to come and get this data. They will submit a whole bundle of this for any number of members to the old health plan. The old health plan will perform a member match operation and will come back with a result that has effectively 3 elements. A group listing that is all of the members that they matched and can comply with the consent request. They will have a group potentially of members that they could not find. They failed to match. And then there may be a third group where, yes, they may have found the member, but the way the member had requested what they wanted to be released, maybe they didn't want any sensitive data to be released. Maybe the plan can't comply with that request. And so that would be into this third bucket. The matched member group would effectively be written to the Firestore to be available as a group resource. And then the payer will be able to make a secure request through the Da Vinci data export for that group ID to be able to retrieve the data. Again, basically the same set of data that we've been talking about from the payer's Firestore. We are allowing for them to be able to define, for example, a date window that they want to collect data for. This is to cover 2 scenarios. One is where there may be a runoff in data. So you move plan, but you still have some claims being submitted after the fact that you've actually switched. And then there's also the scenario where a member may have concurrent coverage between 2 plans. And so at least every quarter, payers will want to be able to effectively query the other payer and say what's been happening so that they can coordinate coverage. We're providing that capability in the use of the Da Vinci data export. So let's go on to the next slide. And with that is a perfect segue to hand back to you, to Alex, and Bob cover the burden reduction IGs.
Well, thank you so very much for that overview, Mark. I encourage folks to put their questions in. We will address questions once we have Bob Dieterle complete the review of his slides. So thanks for coming on screen. Take it away.
All right. Well, thank you very much, Alex and Mark. My name's Bob Dieterle. I am one of the founders of both Da Vinci Project and Fire at Scale Task Force under ONC and now under HL7, as well as the lead for the burden reduction set of implementation guides. I want to start this out by going back in time and looking at why we actually created the implementation guides we're going to talk about now, the ones for burden reduction or prior authorization. We tried to solve a problem that has been significant in the industry, in the ability to go and get authorization from a payer to cover treatments for individual patients in a very timely fashion, one that will allow them to do a number of things, to discuss their treatment options with their provider, the ability to go and have those treatment authorized prior to leaving the practice. This is, by the way, the long-term goal, not necessarily what we'll achieve on day one, so that they can schedule the next step in the care delivery process. It turns out that roughly 30% of people that leave a practice without an authorization or a scheduled appointment don't show up. So what they do is they stop their treatment process, they stop their care process, and what ultimately happens for a good portion of them is they wind up picking it back up in an emergency room or in the hospital. We want the providers to be able to discuss the options in front of the patient so that they can jointly make care delivery decisions. We also want to turn around and have the process by which documentation is gathered by the providers to support prior authorization, showing that it's medically necessary and appropriate, as automated as possible, because much of the information is already in the clinical record. And given the way that we have been moving forward on structured information to meet the requirements of the 21st Century Cures Act, for example, much of it is already structured, whether that's medications or it's diagnoses or it's various procedures that have been performed. And finally, for the payers, we want to automate the process so that they can go and provide the review with a minimum amount of overhead. It also improves the relationship with their members. It improves the relationship with their provider network and organizations. Next slide, please. To do this, we looked at what were originally 3 different sets of interactions that we needed to support. We'll show 4 here because we finally solved a problem that's related to the last steps in prior authorization. The first step we're calling coverage requirements discovery. This is the point at which something is happening clinically or administratively. An appointment's being booked, an order is being placed, whether it's for a diagnostic, for a treatment, for a referral. At that point in time, it's important to go and understand what is covered and not covered by that particular individual patient's insurance plan. So is it covered or not covered? Is it covered in network but not out of network, for example? Does it require certain documentation? Does it require a prior authorization? So this gives us the opportunity at the time, and we'll focus right now on orders, that an order is being placed by the provider to get feedback from the payer regarding all of the things I just mentioned and be able to attach it to that particular service that's being ordered. So we see the payer's response to that particular service. We're calling it a coverage information that will be tied directly in the EHR to the particular service. It also allows us to, and we'll talk about this in a second, short circuit the entire prior authorization process. We'll cover that in a minute. The next step is to gather the appropriate documentation that's necessary to show medical necessity and appropriateness. Typically what you do is you find portions of the medical record, you fax them in after they've been requested by the payer. What we're trying to do is move that entire process up front. The payer at the time of saying a prior authorization is required also knows what information they need in general. And so they can return a link to a particular questionnaire, think of it as a form, an electronic form, that can be pre-populated with information from the electronic record. And that information then can be reviewed by the provider. Additional information that's not in the record can be added, and it can ultimately be the basis for submitting documentation to support the prior authorization. The third step in the process is to go and submit the information, assuming we've gone that far, because there are ways to stop the process at both the coverage requirements discovery and the documentation templates and rules step, but to submit it to the payer. Now, up until this most recent final rule came out, there was an absolute requirement that we had to support, unless you're operating under an exception that was granted to Da Vinci payers, you have to go through an X12-278 as part of the HIPAA requirements. And so we have a process where on the EHR side, everything is FHIR-based, creating a FHIR bundle that then went to, and we'll call them an intermediary, although the way that is organized could be anything from software on either side to an intermediary that actually does translation. But a FHIR bundle that is then translated into the 278 request has all the information that's necessary to go and populate it, is passed off to the payer along with any attachments that were part of that FHIR bundle. So now the payer can go and evaluate the information, respond back using a 278 response. And ultimately, while we have X12 in the middle, we have FHIR implementation on the EHR side. With the new final rule, the 0057 final rule, there is an indication that the Division of National Standards will be issuing an enforcement discretion that if you're implementing the prior authorization APIs described in the final rule, you no longer have to use the X12 278. The last step in this process is clinical data exchange. Sorry. There are times when the information that got submitted during the prior authorization process, gathered through the documentation, templates, and rules, turns out not to be sufficient. They may find a drug that they didn't realize the patient was on. They may have information that has been previously submitted as part of claims that the payer already has, but they need an answer to something else that they couldn't anticipate. So we now have the ability to return a request for information back through the prior authorization support step and have it assembled and completed and sent to the payer using the clinical data exchange implementation guide standards. Next slide, please. Okay, coverage requirements discovery. A number of things have happened since our version 1 was published. We have now put out a version 2 in October of last year. It's referenced in the final rule as the version 2. The specifications have been updated for clarity. We've improved on the functionality dramatically. We have indicated how to go and populate that coverage information extension on any particular service. And we required the ability to use system actions to support automatically performing certain actions, such as attaching that to the service or being able to go and start up the next step documentation, templates, and rules. It allows the payer to also include specifically a questionnaire response, URL, and assuming the information that is necessary to go and approve of prior authorizations available during CRD, either through information that was originally submitted, information the payer may have, or information that they've gathered by using the token that comes along with CRD to access the clinical record. Assuming they have all the information they need to authorize the prior authorization, they can do so right there. They can provide a unique ID that will be the prior authorization number as part of the response in CRD. There's no need to go on through the remaining steps. Next slide, please. So this is kind of the overall workflow. Why are we doing CRD? Takes the guesswork out of all the coverage questions that may exist. It allows patients and providers to talk about what is being covered, what is not being covered, what may need to be paid for and out of pocket. It creates a standardized workflow to exchange that information directly with the payer and the provider. And ultimately winds up pointing to specific questionnaires that need to be completed, assuming additional documentation is required. Next slide, please. Within CRD, there are a number of places in the clinical workflow where we can initiate a conversation between the provider and the payer. We use something called CDS hooks, which allows us to go and fire automatically transactions between the provider and the payer. This can be done at the time that appointment is being booked. And as Mark had indicated, this can also be used by the payer to go and indicate that a treatment relationship is now being requested by one of their members with one of their in-network providers, so they can update the attribution list if it's appropriate. We do it at encounter start. The same thing can be true. You've walked into an emergency room. You now have a new treatment relationship with the emergency room and the emergency room doctor. Okay. How do we tell the payer that so that the emergency room can request data? Well, we do the same thing here. It can be used to update the attribution list. Again, at the payer's discretion, because they may have certain restrictions on who can see certain patient's information. It also allows you to go and do what we call basically cache or pre-stage information necessary to respond in real time to, in this case, we'll talk about the order sign. So the EHRs now, or the payers now know that one of their members is being seen by a provider. They can go and make sure that member is on a particular plan. They can pull forward the plan requirements. They can pull forward the prior authorization requirements. If they wish, they can go back and get experiential information for that particular patient based on prior claims or other information they have. They can stage all that. We're calling it caching, but they can stage all that. We support an order select hook where it's optional. We're not requiring anybody to use it, but that potentially for every single order and actually subsets of an order can reply with certain information that may be appropriate. They're ordering a medication, it may provide information on alternative medications that both are equally effective but lower costs to the patient. And then ultimately order sign, which is what we really have been targeting here. And that's the point at which the provider has ordered whatever services they are requesting or planning on having performed on the patient, whether it's diagnostics, whether it's treatment, a referral, whatever it happens to be, those all go automatically to the payer. And the payer at that point can respond back to each and every one of those, as we had mentioned before for CRD. And then finally, there are situations where we will not have all the information that's necessary at order sign time to make decisions. And so what we do is support something called order dispatch or order set revision. And what that does, it allows us at a later point in the clinical workflow process. For example, it may be the back office that decides or helps the patient decide which provider they're going to see or when they're going to see them. And at that point, then they can send the appropriate information requests to the payer, along with the information regarding who's going to perform the particular service. So the payer can determine whether in or out of network, whether there's special requirements associated with it. But now we have the ability in the back office to go and do certain things that really can't be done earlier in the clinical workflow. Next slide, please. One of the biggest problems that we have been trying to solve, and this comes from providers, it comes from payers, is how to collect the clinical documentation that's necessary to support the fact that what's being ordered is medically appropriate and necessary. And that has been a daunting task for providers to meet payer requirements. Has been a daunting task for payers to get the information they need to provide prior authorizations for particular types of services. And so what we've done is create an environment in which that can be automated. By using something called FHIR questionnaires, the payer can go and either as a static questionnaire or as an interactive questionnaire, they can go and collect the information that's necessary to meet the documentation requirements. By using clinical query language, which is CQL, which is a SQL-like language, they can go and interrogate the patient's clinical record, assuming they have permission to do so, and pre-populate the questions that are being asked. For example, current diagnoses, current medications, have you had an X-ray, et cetera, et cetera, et cetera. Those can be pre-populated automatically from the clinical record using CQL. This stops the requirement that a provider has to enter information or upload it to a portal or go and send it in through a fax. It allows it also to be in structured format, assuming it's in structured format, in the EHR. So this should substantially, over time, cut down dramatically on the work that a provider has to do or anyone in their office staff has to do to collect and submit the clinical documentation necessary to show that this service is required. Because if we're doing it in an interactive fashion, we have the ability to go and dynamically communicate between the provider and the payer, something called adaptive forms. We can do a couple of things. We can walk through very complex care scenarios on the payer side and only ask the questions that are appropriate. It may only be 3 out of hundreds of questions related to a cardiac care protocol. We also can, at that point in time, much like we did with CRD, if the payer already has the information they need to approve the prior authorization because they've already been able to get it from the clinical record or from an interaction with a provider at that point in time, they can return the prior authorization number then. They do not have to go through the formal submission process through PAS. So we now have 2 shortcuts, one at CRD time, one at DTR time, when we can shortcut the workflow process for prior authorization and give the provider and the patient immediate feedback on their ability to have that service authorized. Next slide, please. Oh, and by the way, any approval at this point in time is only an approval. We do not support denials at that point. Next slide. This is the overall workflow involved with documentation, templates, and rules. It's relatively complex, but basically a questionnaire is retrieved from a library supported by the payer. It is pre-populated. There's a prompt for missing information or a review if necessary, and then it's either stored to be pushed through PAS or, because we're doing it as a adaptive form, the ability to turn around and have the payer say, that's it, I've got everything I need, here's your authorization number. So this is standardizing the process of collecting information and exchanging it with the payer for that particular person and their particular situation and the particular services that are being ordered. Next slide, please. DTR can be launched in a number of different ways. It can be launched by the CRD client, which is what we've been talking about. It could be delayed to the back office. It may turn around that the providers decide, I don't want to deal with that, or I don't want to deal with it now. In which case we can just say, fine, we'll launch it later in the workflow process when you or when whoever is going to interact with the questionnaire has the time to do so. It can be suspended in the middle of the session. So, for example, there's certain information that may have to be gathered while the provider's in front of the patient. That can be executed, and then other information that's required from manual entry or the record to be validated that isn't important at that point in time. The whole thing can be suspended and moved into the back office. You can do a standalone launch. For example, it may be that you're not using CRD within that practice, which is not a requirement. These things are optional, at least at this point in time. And you can actually call up and do a standalone launch, get the questionnaires that are relevant from the payer, and complete the documentation using the ability to pre-populate the questions and to affirm that the answers are appropriate. We also can do it through CDEX. So prior authorization support can request for additional documentation. We have a way to go back through CDEX and go back to DTR and execute a questionnaire. So we have a number of different ways that we can work with this interactive ability to gather information from the clinical record, as well as additional documentation that's required by interaction with a provider or the back office staff, and go and submit that as part of the documentation for prior authorization. Next slide, please. Prior authorization support, really the last step in the process. This is what the normal process was prior to the work that we have done. In other words, you go and you submit a prior authorization request using an X12-278. The payer evaluates it, comes back and says, yeah, that's great, but I'm going to need documentation. And then you go collect it. So like we said, we move the whole documentation process up front. Up until now, up until the final rule, we have worked with the requirement under HIPAA that everything had to be in the X12-278 format between the provider and the payer. That has now changed. So let's go on to the next slide, please. So what we've been working with is this process where we collect information in a FIRE format, we create a FIRE bundle, we send it something in the middle that translates it into an X12278, and then ultimately sends it to the payer for processing. We send along the entire bundle always, because there may be a situation where the provider or the payer wants to use the FIRE bundle to actually do the processing for prior authorization. We also send along any attachments. So this would be the information that got collected by DTR, which could include references to things that are not structured. It could be a reference to a PDF, a reference to an image. It could be a reference to a CCDA. All of these things can be included as part of that attachment and sent along. So this is the process that we have been using or have been structured and supported. Under the exception, next slide, please. And now, as part of the enforcement discretion, it's entirely possible to send that FIRE bundle request directly to the payer. There's no need to go through an intermediary and make it and translate into an X12278. The payer can respond back directly to the provider with the FIRE response bundle. So the definitions are all in the implementation guide. Now we are not required, although it may be appropriate to use the X12 standard, assuming that's what the payer needs and supports, is what the provider already has supported. So now we have two options. We can use the FIRE bundle directly, or we can go through the X12278. Next slide, please. There are some new capabilities in prior authorization support that were not in the version 1. And by the way, in CRD, we have a version 2 out, and that's what we described. In PAS, we have a version 2 out, and that's what we're describing here. In the version 1, we had the ability to either poll to find out if something has been updated in the prior authorization. So they came back with a pinned in the normal response time, said, okay, we don't have all the information we need, or we need manual review, and then to find out when something has been updated. In the prior version, we supported both a polling process where the EHR would periodically go out and say, do you have anything more? Do you have anything more? Do you have anything more? As well as a subscription process. In the current version, the version 2, we are only supporting the subscription process. And in fact, we've revised the subscription process so that you, as a provider organization, post a subscription to the payer one time and one time only for all prior authorizations that would get submitted. When there's an update, the payer has the option, depending upon the ability of the provider, to do one of two things. Either send an alert that says, hi, this authorization has been updated, and the provider's EHR can go get that, or to actually return the updated prior authorization bundle. So we now have a much more rational way to ensure that when something happens on the payer side to a prior authorization, the provider is immediately informed either to go get it or by having it sent directly. The other thing we've done is we've added the ability to request additional documentation. It does happen. We mentioned it before. And what we can do now is we can turn around and have either the 278 come back, or through the FIRE response bundle, a request for specific documentation by X12 code, by LOIC code, or by providing a unique ID, basically the TRN, which indicates that there is a DTR questionnaire available to be completed. By using CRD and having it linked back to DTR, we can automate the collection of the information that's necessary to meet the additional documentation required and have it submitted directly to the payer using the endpoint for documentation submission that has been defined as part of CDEX. Next slide, please. This is the overall workflow. It's very detailed. It's not very detailed, candidly. It's a complex workflow. At the top, you see CRD, then you have DTR, then you have PAS and CDEX. The parts that are in pink are the exchanges between what we would traditionally consider the provider system on the left and the payer system on the right. Now, there are a number of different potential interactions or interaction points, as we indicate at the top. Some of these things may not be in the EHR. They may be things that are outside of the EHR. Some of them may not be within the payer's environment. They may be things that are contracted for. But the arrows that are in black and outside of the pink boxes are things that have to happen within the context of those particular systems. So order sign has to trigger this. Response to the provider has to go back into the EHR or go back to the provider. And what we've done in the green boxes is indicated the information that needs to be available when each of these interactions take place to support the interaction information requirement. Next slide, please. So what have we done with these implementation guides to advance the prior authorization process? Well, we standardize the interaction across all payers and providers. There's no longer a unique requirement for this payer. There's no longer a unique requirement for a different payer. There's no longer a unique requirement for a particular provider. We have a set of standards that apply to all payers and all providers for any compliant implementation. We have a standardized way to integrate into clinical workflow. So the payer doesn't have to worry about initiating anything. The workflow does it by itself. When that CDS hook fires at order time, provider doesn't have to do anything. It's automatic. It's behind the scenes. When the payer responds back, unless there's something the provider needs to know, which could be indicated by any number of methods, by a symbol on the screen or stoplight coding that could go from green or red, the provider doesn't have to go and interrupt their clinical workflow unless there's something that's necessary for them to understand. We also have the ability to move a lot of this interaction anywhere in the clinical workflow, whether it's, when the patient checks in, when the provider's the patient at the time of making a decision on treatment, whether it's in the back office before the patient leaves the practice. We have a way to go and touch various points in the workflow so that we have common workflow expectations and we can gather the information with a minimum of overhead on the provider's part, and to the extent it's structured, a minimum overhead on the payer's part to evaluate it. We have dealt with privacy and security. The provider signs off on or has the ability to sign off on any documentation that's submitted. And we have now a way to avoid duplicate entry. We don't have to deal with uploading things to portals. We don't have to deal with faxing in information. We can now do it all electronically. And because these are very flexible standards, they can accommodate new information requirements without going through an upgrade of the standard and a reissuance of the standard itself. Next slide, please. And I believe that's the end. And Alex, I'll turn it back over to you.
Well, thank you so very much, Bob. I'd also invite Mark back on. You can stay on screen, Bob, because I want to take some time to ask some questions. I really appreciate the presentation. There was a lot of content that you both delivered in the overview of those implementation guides that are in 0057. So I encourage folks to offer questions through the Q&A box. And so, Mark, actually, I'd like to chat with you a little bit about some of the content you noted with the patient access API 9115 final rule versus 0057. And, I suspect that the work group is starting to have conversations around the updates, the what's in the policy of 0057, what does it mean to the guides? I'm curious if you want to talk a little bit about some of those conversations, but I think it's also would be helpful to hear how can industry best pace with the changes that are going to be coming to do the incorporate any updates. And so if you want to talk a little bit about that, or perhaps HTI1.
Yeah. Yeah, I think the interesting thing that everybody is trying to get their hands around is the implications of HTI1. So what does that mean? It really, when you boil it down with what we're trying to write as specifications, ONC has moved the goalpost to say we'll no longer, as of 1/1/26, so January 2026, it'll no longer be US Core 3.1.1. It'll be US Core 6.1.0, which is a move from US CDI 1 to 3. So what does that mean? That means that if you're currently publishing your patient access API and you have clinical data in there, it's going to now need to be based on the US Core 6.1 spec. For me, as an author, it means we'd originally created, for example, a medication dispense profile that was suited to payers, since they deal with a lot of prescriptions. That's now a part of US Core, so we've got to make some changes there. The other thing in the patient access API is obviously on the Karen Blue Button side, they've gone to the newer version of that implementation guide. So if you have, as a payer, have dental plans or you have vision plans, there is now profiles that you will use to publish the dental and vision claims. Formulary, as I said, also got pointed to the new formulary IG. It doesn't really change the data that is being made available, which is, which drug tier is your drugs in the list of medications that your plan supports. What it really did is change the way that data was structured, and that was really as a result of feedback we had through the community process to say the original method of presenting that information wasn't ideal, particularly for larger PBMs, pharmacy benefit managers. So it really points to the value of get involved and voice, let us know your expertise. But the big thing we're adding in patient access API is going to be the status and the result of those prior auths that Bob has just been talking about. With that information, the prior auth itself and the supporting documentation is going to now be available in the patient access API. And obviously, it's also going to get communicated to providers and payers through the appropriate other APIs.
Thank you. That's really helpful, because I think that the work groups the use case teams are really talking about these changes, including the HTI1, and I know the USCDI. I'm sorry, the US Core update is a big part of it. So are the work groups starting to have conversations around FAQs? Are they starting to think about the Connectathon and how they can maximize that as an experience to help them get more ready to become compliant? And that's a question for you and Bob.
Yeah, I think we're definitely encouraging people to get involved in testing. We will be testing at the May Connectathon in Dallas, and we'll presumably do the same in September, which I think is Atlanta. We definitely want testing to happen. It really has to happen. And we want to get those APIs up and available in reference implementations so people can really start testing and thinking about how they're going to implement.
Well, and there's also the CMS Connectathon too in July that might be the opportunity. But Bob, so from burden reduction calls, are you starting to get questions from people popping into your use case calls looking for some implementer support? You offer any commentary on how you're helping the industry? You're on mute.
I'll put on mute. We're doing a couple of things on our Wednesday calls. And you're all welcome to come join them. We are addressing some issues that have been found. There will continue to be issues where, we thought something was clear, but they're not quite clear. And so we'll be putting out, a technical update as we need to. But we're also looking at implementer questions when they say, yeah, but if I implement it this way, here's a consequence, or I could implement it like this, here's a problem. And so we try to help them work through the decision-making process that they're going through to understand how best to implement these relatively complex guides. The other thing we're really doing is starting to prep for some of the additional work, I think as Mark had indicated, that will come up as we start to go and make our way from US Core 311 to US Core 610. These are going to, these changes will happen across all the guides that we've been talking about, everything that's referenced by CMS. And that's obviously necessary because ONC has moved the ball forward as part of HTI 1 final rule to indicate that as of 1/1/26, you'll no longer be able to use US Core 311. So we have to go and get implementation guides out, updated and out, so that, and CMS has indicated they're going to come back out with a updated update to their rule, indicating the need for compliance with HTI 1, and we'd like to have them done in time for them to be able to cite the newer version that supports US Core 6.1.
Yeah, there's certainly going to be some updates, and we'll keep the community aware here as we're progressing, as well as, and we'll have the CMS formal guidance. I think that one of the things that really resonated and struck me during your overview, Bob, was the capacity, the flexibility and capacity to really help implementers use these implementation guides in a way that connects and works within the existing infrastructure that they already have and the investments that they've made. So that adds a bit of the complexity, because we have a lot of different models that are out there in the marketplace and implementations that have happened over the years. And so I think it's kind of interesting to see this idea that, we're trying to provide a lot of flexibility. It's all towards the end of, or the end goal of making this as simple as possible. And the workflows, I thought it was interesting to see the approval shortcuts in CRD and DTR to help get that, I shouldn't say approval workflows, I mean the shortcuts of that they don't need to go to the PAS step because you've already gotten the approvals. And so it struck me, though, the variability that could happen when you have to pre-populate a form and the data is not there in a DTR or in the EHR for a DTR to actually extract. And so that really speaks to the EHR workflows needing to accommodate their providers and having that mechanism to prompt that queue. And are we starting to see the EHRs bring around that functionality? And are they demonstrating any of that at Connectathons or in other venues?
Well, typically what we're seeing on DTR, which is, as you said, it's a very complex environment, but the good news is it uses very standard APIs that are already required of the EHRs, the 21st Century Cures Act APIs, the things we're talking about using US Core 311 today. We expect most of those to be Smart on Fire applications to start with, and there are a number of vendors creating those. So we expect it to be external to the EHR in many cases when a lot of these environments go live. There are some EHR vendors who are indicating they're going to bring it inside of their application. So in that case, your question is appropriate. Do we have any examples of them having done so at this point in time? No. We have a number of examples of third parties creating the Smart on Fire applications that can be used. And that's quite successful.
So we're going to have some interesting journeys that folks are going to be on over the next year or so to get ready for those compliance dates. Yes, Mark.
I was just going to add to this. We've talked to a lot of payers. One of the things I think we need to get across to folks is when you look at everything that's been done with the prior auth rule, what we don't want to happen is for each payer to produce their own Smart on Fire app, so that the provider is now back to having 20 different Smart on Fire apps to do a provider prior auth, but it's now bedded in their workflow. And I think that's where we'll see like the likes of Epic and other EMR vendors maybe providing that. So it's one method for a provider to interact with any payer.
I think Bob wants to chime in on that
Yeah,
one.
Mark, I think one of the things we need to point out is that to be compliant with the DTR implementation guide,
Yeah,
any Smart on Fire app is required to interact with all payers.
yeah,
So if a particular payer has Smart on Fire app, that's absolutely fine as long as that app supports every other payer.
yeah.
So that's why we've come out with the interface standards. That's why we said, here is a payer, here's what you need to support. And what I think will happen over time are a couple of things. For those EHRs that like to kind of own their own process, they'll just have their own applications built in. For those that don't, we'll wind up with providers deciding what they want to work with. And as long as they're all compliant with the requirement that all payers have to be supported, we'll have an environment in which providers will make the decision on what's appropriate for them.
Exactly.
So one of the things that we've talked about in this community roundtable and as well as in last month is the clinical data exchange or CDEX implementation guide. Last month we heard about how Providence is using it within their HEDIS measures reporting, and I noted, that you talked about the capacity for PDFs, CCDAs, images to be sent, and so it's really becoming a very much of a Swiss Army knife type of implementation guide, in that it helps with the transporting of all different kinds of payloads to augment other functionality and implementation guides. I'm curious as to any highlights you'd like to offer about CDEX in regards to experiences learned. I know both of you have been working with the implementation guide, or want to add any color or commentary that may be helpful for people as they're starting to pick up that component of the burden reduction. Are you seeing much traction in the market with interest in it, or are people still trying to get their arms around the core, CRD, DTR, PAS flow?
I think what we have seen is the first focus for most of the provider side technology is on CRD. Okay, let's figure out how we can ask the question, is prior authorization required? Or more broadly, ask the question, is a particular service covered? And that's where we see the focus right now for the EHR vendors and for those that are providing an external version of that. We expect DTR to be picked up, I'll say, more completely. Well, DTR is being picked up by third-party vendors that have, like MCG, that already have clinical guidelines that they can use as the foundation for it. We have a couple of organizations that are implementing PAS, and this is typically clearinghouses that already have a place in that, if you will, workflow, particularly with the X12 workflow. Now that we have enforcement discretion, or we'll have it soon, it'll be interesting to see what happens there. We have some payers that have already bypassed the X12 because they are operating under the exception grant that Da Vinci has, and passing that fire bundle back and forth between the provider organization and the payer organization without going through the transformation. So, we're seeing various implementations. I think now that we have a rule and people have a timeline and they understand what's going to be required, that we're going to see a lot more interest in really making sure their organization is going to be ready. 3 years is not a real long time. Not when you're trying to implement something of this magnitude.
Any thoughts there, Mark, you want to add before I ask my next question?
A couple of things. I think the way I look at CDEX is, in many ways, it fits with the FIRE mentality of 80-20. I think DTR is going to provide the ability to set up questionnaires and data collection requirements for the most popular treatments, but CDEX becomes a way to ask the one-offs. And the two things will ultimately, I think, work together. And I think just generally on the rule, one of the questions we get asked a lot is, but they're only, the guides are only recommended and not required. And my response, Bob heard this on, I think on Monday, is, read the tea leaves. CMS is giving very, very strong indications that you should really be implementing these IGs.
Yes, and I was slightly distracted there because I want to do a shout out to Tanya from Blue Cross Blue Shield of Florida for sharing with us that the enforcement discretion appears to just have been released. So I'll post that out for everyone. I haven't obviously had a chance to look at that, but it was going to be my next question to say, does anybody have a sense yet of when we might hear from the feds with the actual enforcement discretion, since it was really only like a paragraph in the press release announcing the final rule? So thank you, Tanya, for posting that. I'll just put that out as a PDF or as a link for everyone, along with a question, whether a service covered, this is a question for you, Bob, whether a service covered and does that service require prior authorization, are two different questions. I'm not sure if she's making a statement or a question there.
Well, okay, I agree with that statement. And if it's a question, the answer is yes, we do both. We took the opportunity at the various CDS hooks interactions with the provider or the payer to, let's stick with order for the moment, to provide all the things that are being ordered. Now, at that point in time, there was a question from any number of providers and payers saying, okay, given that we have told the payer all the things we're going to do, and it is probably less valuable for them to just come back and say, well, of the 6 things you said you're going to do, this one requires prior authorization. When it may turn out that another one is covered if it's in network, but not covered if it's out, or covered out of network, but with additional costs, or requires some other antecedent thing, not prior authorization. So what we elected to do is give the payer the ability for each and every single, not just the ability, but the requirement for each and every single thing that's being ordered, to return a unique identifier saying, basically, I've seen this and I've made a determination that this is covered, it's not covered, I don't have enough information, it requires prior authorization. There are a number of things that can happen at that point in time to let the provider know what the status is as far as the payer's review is concerned. That will be attached permanently to the record in the EHR and give both the provider and the payer a common identifier so that when they return information back through a request for payment, for example, an 837, there's common exchange that's happened in advance indicating that, yep, this is required, or this requires documentation, or this is only supported under certain conditions. And Tanya's conversation is much more complex to build. We understand that. We also think it's far more valuable.
But also seems like this is these kinds of complexities and nuances and problem solving, it's a great reason why people should start attending calls, participating in testing events to really help solve these problems that a lot of people are going to experience. And it does take a village. So you've just seen, thanks to Tanya sharing that the enforcement discretion was released, everything is moving pretty fast. The 3 years is not a long time to get not only the software stack built, but that it takes investments or commitments to make the investment in designing those changes. But then there's the workflow and operationalizing it that is a completely different ball of wax that folks are going to experience. And I know that from a Da Vinci Project perspective, our use case teams are really able to gather input from industry through the implementer support hours or the regular use case calls, and that information is being gathered up. And then as we work to garner clarity, we will share the FAQs and the responses that we get with or through our Confluence page, So and really encourage folks to roll up their sleeves and get involved, or at least track more closely what we're doing, because we're certainly going to have a lot of participants giving us input that we can then turn around and share with others. Because this, as I've said before, takes a village to complete. So with that note, thank you very much to Naomi, who presented on Postable Remit, Mark, who presented on PDEX, and Bob on burden reduction. Very informative session today. We will be posting the slides and the recordings tomorrow at some point, and we invite you to come back to the March 27th event for the next webinar, and we'll be announcing those session details shortly. And thank you for joining us today. Hope you have a great rest of your day.
Thank you, Alex.
Thanks, Alex.